I think that's the one. I don't know which one it was.
Hey everybody, thanks for joining us today on Georgia MemoryNet Insights. We're being joined by Dr. David Loring, whom I get to work with a lot in our Georgia MemoryNet work. And he is a professor of neurology and a professor of pediatrics and a neuropsychologist, and does work in addition to his work in memory disorders, also does work in epilepsy. And so we've been pleased to have him on this session before, and he has some great sessions already videotaped, and we'll put the link to find his prior sessions that you could find and look at in the past, including my favorite 10,000 clock draws and how to do that. So I really appreciate having you here, Dr. Loring, and we'll go ahead and let you kick off. Thanks so much.
Okay, well, thank you. It's certainly a pleasure to be here today. This is kind of a new presentation for me. Just a little bit of background information. As you know, we are fortunate to be able to offer some CME credits. This kind of describes the appropriate things. I have nothing of value to disclose, or no conflicts of interest or anything that will affect what I'm presenting today in my presentation. The overview of the talk is that there's really 4 important things that we need to kind of be mindful about when we start doing a capacity assessment. And I'm going to repeat these several times because they're kind of standardized and important, and we need to remember them as we try to make some of those decisions. This includes understanding, appreciation, reasoning, and ultimately choice. I'm going to review some case examples because as I was putting this together, it seems straightforward sometimes, but there's some issues that really you need to think about a little bit more carefully when we're trying to make those important decisions. I'm going to highlight the screening test limitations that we have because sometimes there's a tendency to overinterpret them. And I think one of the main take-home messages I think I would like you to all take today is the fact that the diagnosis is not equivalent to the capacity or lack of capacity. Traditionally, when we think of capacity, it's had a synonymous meaning with competence, and we've shifted away from that largely because when we talk about competence, it's kind of a big, more global, generalized characterization. So an individual is going to be an incompetent person, be able to make decisions. We've narrowed it down to the use of capacity right now because it can be applied in a more systematic basis based upon the types of skills that we're trying to take a look at and trying to characterize. I'm not really going to go into a lot of detail because this is not really a specific overview, but when we're talking about capacity, it's really a clinical determination. So we as clinicians sometimes have to make judgments. When we're making those judgments, though, it's not a legal enforced context, but rather it's something that does not remove any of the rights that the patient might have, and consequently it can certainly be challenged, and in fact sometimes is, by family members or some others that have a vested interest. In contrast, when we go over and we have the legal side, that is something that's done through a formal court situation, and it removes the individual's rights specifically. But of course, we as clinicians oftentimes serve as the experts to inform that decision-making process. A lot of capacities are discussed these days. Of course, certainly the most global one is independent living, whether an individual can kind of manage it on his own or her own, lots of different skills. As a clinical neuropsychologist, I'm sometimes asked to do evaluations for financial management or testamentary capacities, so whether they can manage the bills, whether they can change their wills, etc. Driving, lots of things. Fortunately, we have an excellent occupational therapy department that people can be done formally. We can make inferences from time to time based upon neuropsychological tests, but it's difficult. Sexual relations is increasingly being discussed and thought about. Certainly, patients that have diminished cognitive concerns, nursing homes, and so on, this is something that needs to be addressed explicitly. Kind of the research and the medical decision, strong overlap. What I'm going to be focusing today, however, is mostly on this medical decision-making, because this is the one aspect of all the capacities that I briefly discussed that we are from time to time asked to explicitly determine before we can go forward with recommended medical interventions. So go quickly over the four important the scriptures for the medical decision-making capacity. Clearly, in this population, cognition is really thought of typically as number one. The individual needs to have the cognitive resources to be able to really understand all the relevant information. So that includes really understanding the condition that they have, and then having a real and a better understanding of the treatment options. So because of the need to have that cognition, they need to be really able to immerse themselves in the specific situation and really appreciate then the consequences of the decisions. So really it's kind of a real processing of the risks versus the benefits that might go forward. They need to obviously demonstrate reasoning in making a choice as opposed to just haphazardly choosing something. And finally, they need to be able to effectively communicate a choice. Second take-home message, when you're looking at capacity, you always round up. You are assuming the capacity for self-determination unless proven otherwise. So here's just kind of what I think we already know, but it gives kind of a nice breakdown about the prevalence of decreasing capacity based upon clinical diagnosis or clinical presentation. So we have mild cognitive impairment, 20%, Parkinson's disease up to 40%, nursing home patients, and again, there's a broad nursing home, so physical and cognitive, 44%, and finally, Alzheimer's disease, 54%. Again, this is kind of emphasizing that point that diagnosis does not equal capacity or incapacity. So when we do capacity evaluation, the important things to remember are it's not necessarily permanent. It may change over time. It may be situational. Oftentimes when there's a grief, some cognitive or psychological component, that can certainly alter the capacity, but that's not a permanent situation and can change over time. Environmental influences are also sometimes important. One of the places in which decision-making capacity is oftentimes a concern is when a person has an acute confusional state and hospitalized with a UTI or similar sort of an infection. Again, that can change over time, clearly with appropriate treatment. And then finally, this issue of incorporating the individual's values and preferences. And probably the example that we best know is with Jehovah's Witnesses who are unwilling to have blood transfusions. And that's obviously the values of the patient that needs to be appropriately monitored and followed. So go through a couple case examples. A 70-year-old gentleman is diagnosed with prostate cancer. So he goes to his urologist, and the urologist recommends surgery as probably the most appropriate treatment option for this particular cancer presentation. Well, patient says, I'm not so sure I want to do that. What other options are available? So at that point, a radiation oncology consult is then offered to the patient. So goes through, gets the information back, and following the radiation oncology consult says, well, I want some more information. Can I have an ethics consultation? That's made. Can't decide which approach he wants to do. So he says, well, I need some more information. So after a request, he seeks follow-up appointments with his initial urologist and seeks actually some consultation with a brand new urologist, seeking more information, always wanting to discuss this more, unable to make a decision. So my question to the group is, would you consider this person to have possessed capacity? Yes or no? Well, the answer is no. And why is that? Well, he was given adequate information, pros and cons for multiple providers, multiple approaches. He has not made a decision nor communicated any choices. Next example two, interesting little scenario. There's a 52-year-old woman who was a high school or college cheerleader rather. She's diagnosed with breast cancer. She started working at a gym. It's kind of a funny scenario because there's an ad in the newspaper where the advertising agency was looking for middle-aged women to promote a new line of gym clothes or something like that. And so she was working at in order to get herself firmed up to as much as possible in order to allow her to then apply and hopefully kind of pursue that modeling career that's always laid dormant for her throughout her life. She says, you know, if I go ahead and I have surgery, that's going to make me discontinue my workouts. And consequently, I don't want to have surgery. So what do y'all think about that? Would you say she lacks capacity or possesses capacity? Well, this is absolutely a yes answer because she provides a good explicit rationale for that decision. The take-home point here is that decision-making capacity involves evaluating the process the patient uses for making decisions, not whether the final decision aligns with our personal preference, if we were the patient, or our treatment recommendations that we make as a healthcare provider. One more, a 60-year-old patient, long 20-year history of multiple sclerosis, is diagnosed with head and neck cancer. No surgical option seems viable, so instead, he's recommended to undergo both chemotherapy and radiation therapy. He declines treatment. He says, I'm not doing great with my multiple sclerosis. I'm fatigued. I'm tired all the time. Well aware that the implications of his absence of treatments, but he says, you know, I really lived a reasonable life and I really prefer to die comfortably. And I realize that my life expectancy is likely to be reduced. So capacity, yes or no? Well, in this case, capacity is absolutely yes, because individuals have the right to refuse life-saving treatment. And of course, it comes with a caveat, specifically that there has not, it is important to demonstrate that there's no overwhelming contribution of significant depression or mental illness, and sometimes even pain that might be motivating the person's desire to forego treatment. So I think it's helpful to kind of go over kind of this decision-making capacity varies by state. You know, it's not a federal law, but it's a state-by-state statute. And in Georgia, decision-making capacity refers to an individual's ability to understand and appreciate the nature and consequences of medical decisions, including the implications of refusing or consenting to treatment. The term inability of any adult to consent for himself or herself means a determination in the medical record by a licensed physician after the physician has personally examined the adult that the adult lacks sufficient understanding or capacity to make significant responsible decisions regarding his or her medical treatment or the ability to communicate by any means such decisions. Again, legalese, I think they just said kind of the same things in my 4 bullet points, but using a lot more words. Also in the code is a characterization of what to do when decision-making cannot be confidently established. If the adult cannot make decisions for themselves and no authorized person is available, the statute provides a priority list of family members who can make decisions, including adult children, parents, siblings, grandparents, and other close relatives. There's also an adult friend provision. If no family members are available, an adult friend who's familiar with the patient's healthcare views and willing to be involved in decisions can be authorized. And what is reassuring here is this physician certification. A licensed physician can certify in a patient's medical record that the adult is unable to consent for themselves and that it's in their best interest to be transferred or admitted to an alternative facility, but the statute provides legal protection for healthcare providers and decision makers who act in good faith based upon the authorized person's decision. So we have some appropriate legal coverage, but it still can be difficult, difficult process because it's ultimately still going to be a clinical decision at the end of the day. I already stated that these cognitive screening tests that we have are helpful on the tails of the distribution, but in the middle is where we need help, and they really don't seem to do such as good a job. For example, if you have a MMSE score, which is mini mental status examination, similar to the MOCA test that many of us use, low scores suggest an inability. Higher scores suggest retained decision-making ability and uh, 6 times more likelihood to have a capacity based upon a cut score alone compared to lower scores. But this is where the intermediate values become and identify the important need for going forward. For example, in a Parkinson's disease series, these intermediate patients, half of them were considered to be unable to consent to surgery. A slightly higher percentage, 2/3, were able to consent to a clinical drug trial. But of course, and not surprisingly, in this decision-making process, there's different standards where surgery is going to require a higher level of confidence before going forward with it than drug trials and drug treatments that can be withdrawn. So again, understanding, appreciation, reasoning, and expressing and communicating a choice. Again, they don't have to make the right choice. There's a high burden of proof as we try to maintain autonomy in our current legal system. If the patient's understanding and rationale are adequate, capacity is demonstrated, although others may choose different options. So, understanding the treatment options, I want to go through kind of the different 4 components that we've had and provide some examples that have been recommended to allow you to kind of explore in a little bit greater detail. What is the understanding of your condition? What are the options for your situation? And what this is doing is making the patient provide information in his or her own words, demonstrating that comprehension has taken place. What's your understanding of the benefits of the treatment? What do you think the chances it will be affected? So what, on the bad side, what are the treatment risks? And what do you think are the chances of experiencing a side effect? And finally, what is your understanding of what will happen if nothing is done? And so we're obviously looking for not just parroting of what was said during the presentation of the treatment options, but a demonstration that there's a comprehension of the risks and benefits and so on. Importantly, though, it's important to understand or demonstrate that the patient can fully appreciate how it applies to themselves personally. So tell me what you really believe about your medical condition is an example that's been provided. Why do you think your doctor has recommended tests or treatments for you? Again, in order to answer that, they need to have a good understanding of the implications of their disease. What do you think the treatment is best for you? Why or why not? And what do you think will happen if you choose this treatment? And what will happen if you don't treat? Again, trying to drill down on those risks and benefits and the comprehension of that dichotomy. Also, the reasoning has to really be supported by facts, meaning they have to compare choices. What factors, issues are important to you in deciding about your treatment? What are you thinking about as you consider your decision? How are you balancing the pluses and the minuses of the treatment? And do you trust your doctor? Why or why not? And this is one that I think we run into a little bit more frequently because there's some historical reasons why certain groups may not fully trust their treating physicians. But the other thing that is coming up more and more for people younger than me anyway, is the influence of social media and internet information, where somehow the information that's found online is somehow more trustworthy than the specific physician that is under the care. What do you think will happen now? Obviously, they need to express their choice. So you've been given a lot of information about your condition. Have you decided on what medical option is best for you now? We've discussed several choices. What do you want to do? So here's another example, kind of pulling some of these things together for you. We have a 75-year-old man who declines metformin prescription for new onset diabetes. He said, "No, don't bother, doc. I already take too many pills." So in his response, he has 2 of the 4 decision-making abilities that we've talked about. He said a choice, don't bother, I don't need it, and consequential reason, I already take too many pills. So it might be easy to say, okay, that's fine. We can go ahead and we don't need to bother. You have the capacity to decline treatment in that situation. The problem with that scenario is there is no inquiry whether there is a appropriate and appreciation of the clinical diagnosis or the clinical implication. So sometimes in certain conditions, there can be impaired insight that limits the appreciation of the diagnosis or the implications of a diagnosis. So it's important to acknowledge both the diagnosis, but also drill down and find out specifically what will happen if the treatment is declined, as indicated in some of the previous questioning. So the patients may not appreciate those implications, even if they can kind of parrot back to it. So we get down to the reasons. Is one pill really too many pills to take? What's the consequence of one more pill? That's the kind of discussion that in this situation that would be important to have. In general, the patients may decline risky or time-consuming hospital-based treatments, however, because they value being at home in the family. So in a different situation, how is having the in-hospital treatment better than having it? Well, it would certainly be they want to spend more time with their family. There's a number of structured or semi-structured interviews when the decision or capacity question can't be really answered as quickly or as definitively as possible. I'll leave them here so they can be reviewed. I'm not going to go over them in any detail other than to point out this last one that I'm presenting here, this aid to capacity evaluation. It was developed in Toronto, I believe, so a little bit of the rules, but you can see it goes down, and the first 4 domains are assessing, again, important factors that we want to do. It contains questions pretty much that we've already gone over, and I'm not going to repeat all of them necessarily here, but again, it kind of points you in the same direction in terms of the understanding, the treatment, and what to do. Importantly, if you remember, I mentioned that we need to be mindful of the fact that there may be psychological or psychiatric components that might be influencing a person's decision. And this kind of, again, points you in the right direction for depression, or they mentioned psychosis. I think that's probably referred more to some of the confusional state that we sometimes will experience during the hospital evaluation phase. So, the medical decision making, it's typically determined by the attending physician. Again, I want to point out it's a clinical decision making. It's not one that's enforced by law unless it's challenged and it goes through that route. I'm a neuropsychologist, and I sometimes take a consulting or an advising role, but it's important to realize that by and large, the evaluations that I'm going to be doing as a neuropsychologist are going to be more on the lines of addressing the financial capacity, ability, or whether an individual has the cognitive decision-making on a more cognitive capacity in order to change will, particularly in the later stages of life when there may be some cognitive issues that are being concerned. So, real, as I kind of wind down before we have a little discussion, if we have time, it's always important to presume capacity. So you're going in there with the goal to demonstrate that a person is able to engage in important decision-making capacity rather than going in there and trying to look for ways to exclude that ability. Again, as important as a take-home message that I can emphasize in this presentation today, diagnosis is not equal in ability. If you recall, half of the patients with Alzheimer's disease in that prevalence slide were able to execute and have appropriate capacity for medical decision-making. Although the flip side of that is, roughly half of them were unable to do that. It's also important to kind of focus down into the ability to do the specific task or decision. And this kind of applies, I think, a little bit more to the specific sorts of capacity areas that I was presenting at the beginning of the talk today. Again, support before you subtract. Presume capacity. That's your goal, is to demonstrate it rather than to subtract away from it. And again, restoration is possible. Situations, the acute confusional state, who's hospitalized in the hospital. At that time, consenting can't necessarily be established, although when it's appropriately managed, the patient can be discharged and go home. Similarly, if there's significant psychiatric issues such as depression or worse going on affecting, those treatments can be provided, and the final decision is not necessarily going to be that a person is unable to consent throughout the rest of the individual's life or time, but rather following successful treatment, that should be appropriate. Finally, in this slide, gets into the issue of following through with recommended treatment. The person has the absolute right to deny the decision going forward for specific medical treatment. And probably the clearest example of this is a patient who leaves the hospital against medical advice. That specific activity does not imply that the person does not have consenting capacity. So as I kind of wind down with my last couple minutes here, the fundamental elements of decision-making capacity with respect to medical decision-making include understanding. So it requires us to go through and demonstrate whether they're able to understand all of the relevant information. It requires a demonstration of appreciation, meaning can they apply all the relevant information to their personal situation? Reasoning, can they engage in the effective weighting of the pros and cons of whether to go forward with the treatment or declining treatment and what the implications of that are? And then ultimately, can they appropriately communicate their rationale and the background behind their choice to their providers? And with that, that's my last slide. I'd like to thank you for your time right here real quickly. I'm including references here for people who may choose to drill down a little bit more. Most of the case examples were from some of these references here provide, hopefully provide some thoughtful discussion of the pros and cons and the issues that need to be appropriately addressed. And finally, I'll kind of turn it over. This is
Great.
the Q. I'll turn it over.
Yeah, thanks so much. This QR code gets you to an online version of an opportunity to fill out an evaluation. And I put the link in the chart as well. Hey, Dr. Loring, thanks so much. You did a really great job of presenting a very clear. And let's go ahead and just go back one slide. Thanks. We'll just leave. We'll leave that off.
Well enough alone.
It seems to have.
That's an example of a treatable condition, right?
Thank you for that. We have so many interested parties on this call here who do this on a day-to-day basis. We really appreciate your clarity here. Even with understanding all those principles, it can be very, very challenging in day-to-day clinical practice. And so wanted to see if anybody wanted to come off mute to ask a question. I don't see any in the chat right now. And I'm going to call on my MedSite colleagues. Someone's got to come off mute and ask a question, please.
Sure, I'll ask a question. So thank you for your lecture. I am interested a little bit in a challenging scenario that we sometimes come across in which a patient seems to demonstrate capacity to refuse a treatment, but lacks the practical ability to leave the hospital setting. And I'm wondering if you can comment at all on how the practical ability to carry out one's decision plays into the determination of capacity, and whether or not you feel, the determination of capacity should subsequently incorporate that.
Yeah, thanks. That's an excellent question. And I'm not quite exactly sure the best way to answer that. I'm not sure I fully understand it. So there's a hospitalized patient, and
perhaps I can provide an example. Yeah, perhaps I can provide an example.
Yes, please.
A patient has osteomyelitis of the leg, and the osteomyelitis is fairly severe, and it's expected that they will lose their leg. And the recommended treatment is surgery, say to remove the forefoot.
Mm-hmm.
Let's say that. The patient is unable to ambulate due to pain.
Right.
And they state they understand that if they do not have surgery, their infection is likely to get worse, but they are somebody who does not want surgery, and they have never engaged in surgical procedures in their life, and they understand the implications, and they're still refusing. And they also say, I would like to leave the hospital now. How should that decision be approached?
Well, if I understand correctly, it's very similar to, I think, the multiple sclerosis patient that did not want to have surgery for the head and neck carcinoma. So demonstrates, I assume he's aware that the absence of treatment causes significant risks. I think the 4 elements that we have discussed have been met. So then like I said, it's a little bit outside my wheelhouse, but this is, I think, then something for the social worker who hopefully is involved with the care to manage the appropriate placement in the home health transition. I mean, if I understand,
Yes.
I think the capacity
How about
elements have been adequately addressed, and the individual that you describe has that capacity to choose not to go forward with any sort of surgical intervention.
how about capacity to leave against medical advice in that setting?
Well, this is a physical capacity that you're describing, I think, rather than a cognitive decision-based capacity. So he has the capacity to leave. If I understand again the question correctly, and it's more an issue of the management while he's unable to provide adequate care for himself.
I think the point about physical capacity is well taken, because I think we can become, as hospitalists, so my setting is as a hospitalist. As hospitalists, we can, I think, become confused about the ability to the capacity to leave, the decisional capacity to leave AMA versus the practical ability to leave
Right.
AMA.
That's it. I agree with that distinction, because this is primarily the cognitive decision making, which exists somewhat independently from physical independence.
I was speaking to an ethicist recently who said that a case came about in which the hospital determined there was an obligation for the physician to assist the patient to leave the hospital, even though the physician was not recommending discharge and the patient was physically unable to get themselves out of hospital, physically unable to ambulate or operate an assistive device to get out of the hospital.
Well, that's an
I think
interesting
is an
case.
interesting implication.
And this would be one that I would immediately defer to our attorneys and medical risk folks.
Thanks, Nathan, for that question. And thanks, David, for just going back and applying those 4 pillars that you talked about there. And I think that it may seem like hair splitting, but I think it's very helpful to be talking about the difference between cognitive capacity versus
decision
the
making.
physical. Yeah. Yeah. Thank you. Cognitive decision making versus the physical capacity to execute on that plan. All right. Hey, thanks so much, everybody. Really appreciated you coming on today, and look forward to seeing you next time. Thanks again for signing on, and we'll be sending you some emails just to let you know about future cases. Dr. Loring, thanks so much again.
Okay,
really appreciate
enjoyed it. Have a good day, everyone.
Thanks. All right, bye-bye.